This call is now being recorded.
Hey everyone. Hey everyone. This is Trevor Karbowski, PharmD, and Kenton San Miguel, both co-founders of DisEASE. Our team's been extremely busy the last 6 months. I think, Trevor, you can attest to that, right?
Sure.
Yeah, but all good things, all good things. We're excited to kind of come out of the trenches of our build and really show you all what we've been working on the last 6 months. I think based on some of our LinkedIn posts and our most recent article, there's a lot of energy around what we're essentially doing. And that essentially is probably one of the reasons why I think we kind of wanted to put together this, to be frank, informal presentation or video recording. I mean, for folks on the call here, I mean, you're gonna hear you're gonna hear other things. You may even see a bug or two, right? But I think the main thing here is we're trying to ultimately provide transparency, trust, and really guide the way that we think clinicians can work in the future. So without further ado, let's jump on in. So Trevor, I'm sharing my screen, right?
Yeah. So as Captain he's going to plug in some of a case that we sort of created just to sort of give you a little bit of a feel for like what we're trying to accomplish here. Ideally, what we're really trying to do is just break down recommendations like at a drug level. We're trying to essentially streamline polypharmacy practices. I see it very routinely where we tend to throw meds to fix problems, but sometimes we don't always look at the patient as a whole. It's not always a perfect scenario, and having a way to sort of break that down and find some of these barriers, we feel like this could do some good for patients. And as Kenton said, we've learned a lot on this journey. Myself, very, very naive to AI and things like that. However, I knew how things should work in clinic, and that's sort of how we built this. And then that's where the developers kind of brought in their own twist and sort of helped bridge my knowledge, and actually got me up to speed to where we could really sort of take this to another level. Actually expanded my thinking, and even honestly through creation of this, I found some of my own biases that I had working with some of these medications, and I've been able to discover new things within this tool that honestly wasn't even aware of. So it sort of has opened the eyes even to me, of what potentially AI could be in healthcare. So go ahead. I know Kenton's kind of filling in some of those gaps there, but
yeah, Trevor, do you just want to kind of speak to, I mean, you touched on a little bit how we're kind of collecting some information, but can you kind of speak to what we're trying to kind of show users at the same time here on the left-hand side? And I'll kick this off right now.
For sure. So basically what we're doing is, you've probably heard a lot about prompts and seen some of that for some in the AI healthcare space. This is kind of our way at a very structured prompt, okay? And what we're kind of doing is, on the right-hand side, there's more of that structured fill in the gaps. Here's what we need. We're also adding, because what we noticed is that just a straight prompt can sometimes be slow. So we're kind of trying to develop a sidebar to speed up this process. Okay, so this Dr. Ease can help fill in some of this med to essentially get us to the bread and butter of what we're going to get to, which you'll see here once we get to that recommendation page. But as you can see here, our Dr. Ease bot was helping fill in some of the gaps that we may have missed. Obviously, you can see he's not perfect, but he would save you a lot of time right here. So
Trevor, I think this is, sorry to cut you off here, but I think this
good.
is a perfect example of what we're trying to preach and teach with our LinkedIn, our communications, and even our article, right? Like, we can do our best to try to essentially confine these AIs with RAG, right? To all the way down to the chunks, to how we prompt, how we essentially enforce memory, etc. But as you can see, we still face the same issues. And to be frank, I I haven't actually hit this one today, right? I'm just hitting it now the first time, and I've used this same drug. So anything else you want to add to that, or does that kind of resonate with ultimately
Yeah.
what we're going to show here in a second?
Yeah, for sure. And then that will even kind of, as we lead into that recommendation page, we'll also show you where we sort of do take the gloves off and we say, AI, you're just not allowed to touch that a little bit. And as you'll kind of see with our, through that Decoded series, the whole nine, like everything has its place, and everything has its strengths and weaknesses. And I think that's one thing that maybe, myself, healthcare isn't fully transparent on. Tech, the other side, isn't fully transparent on. So that's really where we're trying to bridge that gap, because we feel like honest communication is probably what's going to be the ultimate guider of truth to really getting these systems locked and loaded. I don't know. Is there anything else you wanted to touch on in this recommendation page, Kenton?
No, I think, obviously the only caveat I would say is obviously we're asking for a lot of the inputs. First thing is you would notice that there's actually no sort of PII or true PHI information that we're collecting. Maybe you could argue age, insurance together, but we're doing that on purpose, right? We're trying to make sure we ask the minimal amount of information that allows us to be successful in what we're going to show and try to do here, right?
Yeah, good point.
But I think that's it. Should we go ahead and let her rip?
For sure. Yeah, go ahead and let her. And even kind of touching on that too. We know that these prompts can be, and that's where part of this is too, is we know that through like partnerships and stuff like that, finding different people to work with, like we can definitely make this quicker, to get to this bread and butter page. But that's like this expansion of trying to get us here, because this is ultimately where our patent lies, where we kind of feel we are different than everyone else. So the biggest thing to really point out here is these deterministic scoring. Okay. This is ultimately where our ultimate truth lies. Okay. And this is where, when you've seen us talk about deterministic models, the AI hallucination, everything like that, this part in the tealish blue, this is our controlled environment. This is where we don't really allow AI to even intervene other than adding up the numbers. So actually, if you even want to break that down, Kenton, and show how it's actually scoring, we're essentially, this is how we're doing it. We are essentially looking through guidelines, assigning like, hey, this is a baseline score, and then using those factors from that form to add weight to how we're ultimately deciding the best approach for this patient. Okay. And it's not always going to be the exact same weights applied to each patient, because really, when you think about things as a clinician, nothing is a black and white answer. There's always going to be certain scenarios that may steer you one way or the other. And as I'm sitting here training a resident, that's one thing I always teach them is train yourself to know the answer for every scenario. Okay. Now, not to be perfect, but say if we're in a diabetes case, I would want them to have somewhat of 1 to 2 thoughts of, hey, this is a good option, this is a bad option, here's a reason why. And so kind of developing that scar tissue, you sort of learn to, in a way, start to be less reliant on this tool, which is ultimately our goal. How many tools are really out there saying, we want you to get so good that you don't need us, and that's where really we kind of are leaning on the teaching method and showing you, hey, this is kind of a way you can weight this product. This is going to push you and start to develop those scar tissues, to where once you see enough cases, you're going to be able to almost have this type of thinking, or and not so much clinician bias thinking, but like develop these thought processes of, okay, this type of disease state or this comorbidity I need to look at this drug class a certain way. And that's where we really are trying to help with this. And this isn't quite in there yet, but even like with these scorings, these will be tied to specific guideline chunks, the whole kind of nine, to show you that this isn't just a black box reasoning. This is truly something that's ADA backed, AHA backed, ACC, you know. So that's kind of
Trevor,
my
to that,
feel.
yeah, to that point, should we kick off one of these to kind of show what that generative layer comes in? I mean, I don't want to get too like in the weeds of the technical piece here, but I would just ask and challenge folks to just take a look at our logo, right? Where it's half gear, half, tentacles. And I would just say like everything that we've done is intentional, right? Like we are trying to bridge the gap, understanding that AI is extremely powerful in some areas, whereas not in other areas, right? Case in point, this clinical fit, right? To me, this is an area that unfortunately LLMs, AI, knowing what they are under the hood, right? Essentially predict the next token, the next word type of tool. Like that's never going to be essentially 100% accurate, right? And what I mean by that is ultimately, if I took this same workup and I generated the same recommendation today, an hour from now, 200 days from now, obviously, with some, guardrails in place, we're going to get the same score, right? Whereas if you take your typical LLM, your ChatGPT, whatever AI tool you have a subscription for, and you try to mimic that, you're going to get a somewhat similar answer, but you are going to get slight differences, right? And that is where essentially the hallucination and the drift starts to come in. So again, have part of the gear, and then from there, we are essentially using all the scoring, our underlying foundation of the rules, the clinical concept chunks. We're using that as our grounded data to then use AI to truly summarize what it is that they're seeing. So I'm going to go ahead and click that, and just, Trevor, you want to kind of speak to what we're doing here now with our Mr. Ease?
Yeah, so and he is kind of, so the way I kind of look at this is, don't look at this page as like if you're looking at it in the lens of a traditional LLM, you're probably looking at it wrong. Okay, so because we did intent, as Kenton said, we've tried to be as intentional as possible with every single thing we're implementing. So the way we're trying to do this is something where you can run this mid-clinic, okay, where you could actually realistically, if you're stuck, you could put this in and try to get, hey, here are my actionable items. Here's probably the best course that I should tackle this case with. Okay. Now, if you do want to do some of that deeper digging, see where it matches and meshes, this is where our ease kind of comes in and kind of steals the show. Okay. This is where we start to show some of that generative AI and thinking, along with that assessment and that clinical assessment in there in the middle. That's where we're kind of giving it the, as Kenton said, we dial the heat up a little bit on the temperature. So we're giving it a little flexibility to kind of put its own spin on what we're thinking. Okay. However, what we also do is we regulate that by saying it must reference those rules. Okay. And that's where you start to really get some answers that are grounded in evidence, grounded in truth. And then the other kind of caveats is we have some of these other APIs and things like that we're pulling, because no guideline's perfect, and these other APIs are diverse enough that they can kind of catch some of these things. If you have a question about a clinical trial, maybe a package insert deal, we still have the diversity to come up with some of those answers for you, and we're not going to sit here and say we're the all encompassing truth on some of those miscellaneous opportunities, but because of what we have, we feel really confident with the disease states we have. So and that's part of why, even like where you've seen a lot is they'll say, oh, we've come up with 55 disease states in a 2-week span, and it's like, that's awesome. If you can truly spit out a repeatable outcome, like, that's great. But it's the edge cases that I found the biggest weakness, and that's why we have intentionally stuck to these three, and we want to make this work to show that this is something we can duplicate and emulate for every disease state. I don't know, Ken, what do you want to add?
Yeah, I mean, obviously, I think we want to try to keep this as brief as we can, but I think hopefully folks are kind of seeing the power of what we're trying to bring here. I mean, it's not your typical, LLM or AI startup, play here. Like, we're essentially really starting from ground zero with like what's in it for them. And so I think, Trevor, maybe if we can just segue there to just talk about like where do we see this tool essentially fitting best? Can you kind of speak to some of the EQM boost stuff that essentially is a big opportunity for us?
Yep. Yep. So where I kind of see this, and a lot of it does kind of tie back to this education training piece. A lot of things with particular kind of focus on primary care setting. EQM scores major reimbursement deal for providers, for healthcare systems as a whole. A lot of those kind of simple things are sometimes easily overlooked. Um, and that's where we do have these EQM reminders. We sort of have things pre-built in our clinical notes section that we will help you develop with that assessment and plan, that sort of reinforce like, hey, these are the administrative tasks that we need you to complete. It's not even so much as like, hey, and this is the other caveat is, yes, not just checking a box to check a box, but does it make sense to check that box? Okay. If, say, for instance, they're not on that statin, document why, and that can still justify some of those EQM scores. Okay. So don't just check the box to check the box, but documenting it correctly. Okay. That can be a huge way to reimburse some of these EQM scores. We also know just from simply drug selection that typically when you keep patients on fewer amount of meds and get the best results for them, they're going to trust you more. They're more apt to take their medications. Adherence is going to be better. So we kind of even are envisioning some of that will naturally lead to better diet, better A1C scores, better blood pressure results, things like that. Okay, so that's kind of where in the primary care realm we feel we're going to offer some impact. Okay. Now, sort of even tailoring this, we also see a pretty good opportunity in the educational field. Okay. In all reality, I think this is pretty obvious to most healthcare providers, but specialties are becoming more scarce, and more is getting pushed on the primary care provider to be the specialist in the room when they may not feel super comfortable doing that. So having some of these pieces where we're kind of teaching them to build that scar tissue with these certain thinking strategies, that's ultimately what we're trying to do. We want you to be able to use this to get comfortable managing maybe the uncomfortable disease state that you see. Okay. So maybe you, instead of immediately referring them to that specialist, you implement steps one and two, and then once you get to three, you say, okay, I think I need to send this up. Whereas versus prior, maybe you didn't even take that first step. So we also think that's going to put less strain on the healthcare system as a whole. Even in education, we do think there's some opportunity here with how we break down these baseline scores, to potentially show new healthcare professionals, because this, in all reality, this is something that I would practice with a resident, so being able to teach them kind of reinforce some of these thinking strategies, maybe let them almost in a way tell them, yes, you're thinking properly on this, or allow them to test themselves on cases. It sort of helps reinforce those good habits. And I guess one thing we really haven't even touched on either is one of our core principles was helping uninsured populations. That's definitely one of an area we want to grow and develop some better, not so much pricing tools, but pricing data. So that way because we know we do such a we do a good job with breaking down the drugs. We want to sort of marry that with also the costs that are related. Now we're not trying to be a real-time pharmacy benefit manager. That's just not us. However, when you have that patient who is uninsured, it really does change how you manage that patient population, as much as maybe we don't want to admit it, but it really takes a lot of meds off the table, and giving that clinician even somewhat of a fighting chance and saying like, hey, here's what that copay is going to be, maybe, or roughly what it's going to be. Have that discussion with that patient, because maybe it's just that simple adherence that's gonna get them there. And we actually even have some of those things kind of cooked into our rules already. But there really are, there's a lot of potential to expand the actual inner workings of even what we have.
Totally agree. And I think just to go back to your comment around just the education and not ultimately reliance. I mean, coming from my stance, right, strictly kind of architecture and technical background, I am starting to pick up on things, specifically, EGFR and how it plays a role in how we dose metformin. You can see it listed right here as well, right? Like that's an example of something completely out of the realm of what you guys do day in, day out, right? Saving the world. I can pick up on that, right? And I don't become reliant on an AI tool. So I think that's actually an interesting point you mentioned. Obviously, we can share a ton more on this. I think we're super excited. Like I said, we are just kind of coming out of our kind of build cycle. We are excited to share the world our new tool. So with that, whether you're a partner, whether you're just an avid, and fan trying to research, or clinician trying to research, somebody in education, reach out. We have our LinkedIn, we have our website, DisEASE.com, and we're really just trying to build applications or systems that essentially are going to help the greater population, right? And so I think with that, Trevor, I think we call it a wrap. Hopefully folks enjoy this video and many more to come.
Yeah.
All right. Bye, everyone. Let me see if I can get this guy back up.